Hi, my name is Dr. Don Buford. I'm an orthopedic surgeon based in Dallas, Texas, and I'm the director and founder of Texas Orthobiologics, which is a clinic that combines regenerative medicine techniques with orthopedic surgery. I'm sports medicine fellowship trained, so my orthopedic practice primarily focuses on sports medicine. In the regenerative medicine world, I treat all orthopedic pathologies. The assignment I was given for this talk is orthobiologics in adolescent and collegiate athletes. I'm very grateful for the chance to participate in this meeting and sorry I can't be there in person. These are my disclosures on our Academy website. I wanted to start off by talking about some definitions because there's obviously a very big difference between an early adolescent at age 10, like you see on the top left here, versus a college senior who's done growing and is about to go out into the professional world, as you see on the bottom left here. I'm going to focus this presentation in the time allotted more on the skeletally immature adolescent and less on the collegiate age skeletally mature athlete. Just like there is in the male athlete, there's a big difference between a 10-year-old female, and on the top right there, you see a 10-year-old Serena Williams versus a 21-year-old number one or number two tennis player in the world who would be Iga Swiatek on the opposite side of the court there, away from Coco Gauff. So I'm going to also put out three position statements, kind of as take-home messages that are really independent of the topic of this talk. Number one, we should consider orthobiologics for any injuries that have not healed in the accepted time frame. Number two, we should consider an orthobiologic for any injury if it has been shown to accelerate healing or to improve surgical outcomes. And finally, number three, we should consider orthobiologics where there is evidence for good outcomes and the surgical options are not ideal because of recovery problems, risks of surgery, or post-surgical development, some of which may happen decades downstream, for example, after an ACL reconstruction. So what are we talking about in terms of orthobiologics? Well, these are the things that I'm focused on: bone marrow aspirate, bone marrow concentrate, platelet-rich plasma, platelet-poor plasma, adipose, in particular the microfat version that's not considered stromal vascular fraction based on recent court rulings in the United States. What I'm not talking about are orthobiologics that are currently not approved by the FDA for human sales and use outside of an FDA-approved study in the United States. And so in particular, we're talking about Wharton's jelly, placental matrix, amniotic fluid, exosomes, and I'll even throw in peptides because I'm sure all of us have had patients come in talking about peptides. So which orthobiologic to use? The data changes almost weekly. And so I would urge all of us to stay evidence-based and to follow the clinical science for the best protocols and dosing. There are so many different potential indications and in some cases established indications to use orthobiologics that we have to stay on top of the data. At this point, I use high-dose platelet-rich plasma at least 80% of the time in my clinical practice simply because it has the best outcomes at the lowest cost for the most orthopedic indications. Where that isn't the case, then I consider a different orthobiologic. I want to take a couple slides and talk about platelet dosing because that really is a hot topic. Most papers that are coming out now that evaluate dosing are discovering that higher doses lead to better clinical outcomes and really shouldn't be a surprise. That holds true in a lot of pharmacology. This is how different the dose can be in PRP. If you have a patient that starts with a platelet count in this example of 267, if you run that patient's blood through a system where the protocol is to draw 30 cc's of blood to make 3 cc's of PRP, and the protocol only concentrates 1.6 times over baseline, that is only going to create a platelet dose of 1.3 billion platelets. However, if you take that same patient and just use a different system where you draw 60 cc's of blood and that system concentrates 5.5x and makes 6 cc's of PRP, well, now you've got an end product, an end biologic drug that has almost 9 billion platelets. The difference in dose is 7 times. Same patient, same blood, same day. Simply the decision of which kit to use makes a tremendous difference on dose and therefore on clinical outcomes. So if you haven't paid attention to that, it is high time that we all start looking at dose that we all start evaluating the kits that we're using and the protocols that we're using. This is something we put out in 2023. It was one of the early articles that tried to summarize and quantify the difference in dosing. This particular effort was geared more towards soft tissue pathologies. And what we found was if you have a cutoff line of 3.5 billion platelets as your dosing cutoff line, 14 out of 14 studies that we evaluated showed that PRP did not help clinically if the dose was below 3.5 billion platelets. On the other hand, in the studies that showed doses above 3.5 billion platelets, 9 out of 11 showed positive clinical outcomes, statistically significant clinical outcomes. So the take-home message is pretty clear. If you're treating soft tissue with PRP, find some system that gets your dose above 3.5 billion platelets consistently, reliably, and predictably. Now, here are some potential indications in the adolescent population for orthobiologics. The ones in green are ones I'm going to spend a little more time on, but really, almost anything that brings someone into the office is something that could potentially be treated with PRP, again, if it fails to get better in the normal healing time that we all know how to manage. So now I'd like to present several case studies illustrating the potential, and in some cases, the already here utility of orthobiologics when we're dealing with skeletally immature adolescent athletes that are high-level athletes that want other alternatives besides surgical interventions. This is a 14-year-old soccer player. He came in with his parents. He had a pretty significant soccer injury to his knee. They've seen two other orthopedic surgeons in town, both of them excellent orthopedic surgeons, colleagues of mine. Both of them recommended surgery. And now the patients have found me because they want a third opinion for what's been diagnosed as an ACL partial tear and a medial meniscus tear and a grade 3 MCL disruption off of the tibial insertion. So again, not unreasonable at all to suggest surgery given that constellation of injuries for a 14-year-old who had a significant traumatic injury to his knee. We had a long conversation, probably more than an hour, discussing pros and cons of an orthobiologic approach and how that may not get all of the things accomplished that I think would be important to get this knee stabilized. And even given the understanding of the limitations of orthobiologics, I had to have the ability to still do surgery if I felt that was the right thing to do. And so what we decided was to do an arthroscopic diagnosis. We decided to use bone marrow concentrate to treat the partial ACL tear and to treat the meniscal tear potentially. So what we decided to do as a treatment was to do an arthroscopic evaluation first, because that really is the gold standard for these intra-articular injuries, and also gave me a chance to examine how unstable the knee was in varus valgus with his MCL disruption. The MRI scan showed that the tibial insertion of his MCL was essentially not in the same building. And so we knew up front that I was going to at least make a very small incision. And luckily, at his age, we were able to just put it right back down with some suture anchors, right back down to its insertion. So that was already a given. The question was, even though we would be doing surgery under anesthesia, did we want to put him through some sort of ACL reconstruction, given that he's skeletally immature, has a lot of growth left, and also has this medial meniscus tear? So we examined the knee, and what we found first, in looking at the medial meniscus, was he has a tear in the posterior horn. Now, there are some of my surgeon colleagues would say this is a ramp lesion or a root tear and would devise fantastic surgeries that would most likely work. My question was, could I do something less invasive, didn't require sutures, didn't require drill holes through the bone or through the physes? And this is what we came across. And so what I decided to try was something that didn't require drilling across the bone, didn't require drilling across the open physes, and we use bone marrow concentrate here. So we inject at the meniscocapsular junction, we inject into the basically red-white zone of the meniscus as well. I did that after making sure that the meniscus was stable through range of motion and through stress. For the ACL, we confirmed that it was essentially intact, that the sheath was still intact, but he did have this partial tear. And so what we do here in terms of the technique is we inject each bundle, anteromedial, posterolateral, at the tibial side, mid-bundle, and then at the femoral side. So it's a total of 6 injections just to make sure that we completely cover the ACL. And we count on that sheath acting as a scaffold. This is a video of him 8 days post-op. The other agreement I had with the parents is we were going to document this and we were going to essentially have them move into my house so I could track this child very, very closely because I did not want to get in a situation where we lost track of him after this procedure. So at 8 days post-op, he's got minimal swelling. He's got that one small incision closed with some monocryl where we put down the MCL, but no other incisions. We did not do anything beyond what we just showed in the video. He's already got pretty good flexion, as you see. And again, this is 8 days post-op. So here we are 2 months later. He's doing great. He's back at full sports. He has no complaints. In this interview, he tells us that he has zero pain. He has no instability. He's playing a lot more basketball than soccer, is what he tells us. And his parents confirm all of this. They're just off camera to the right. And so he's shaking his head that he has no significant complaints. So we're very happy with this result. Again, this is 5 months out from the procedure, so we're not quite patting ourselves on the back yet because we have years and years ahead of us to see if this is durable. But it sure is a novel way to approach somebody without a complete ACL disruption and with a stable meniscal tear. So at 15, I discharge them. I make sure they have my cell phone. I make sure they have my email. I make sure they know how to find me. And I say, do whatever you want to do, but give me a call if there's any concerns at all. And so he goes away at 15, and I don't hear from him until about 4 months ago when he's 23. And he didn't come back to see me because there was a problem from the procedure we did when he was 14, 15 years old. He came back to see me because he was playing basketball and stepped on someone else's foot, had a significant traumatic injury, and now actually has a complete ACL tear and has torn his lateral meniscus. It's kind of interesting. The medial meniscus that we saw before that was torn actually was fine. And so here's a video because we actually ended up reconstructing his ACL this time. Getting started on this right knee. We're looking in the medial compartment first. You've already harvested your hamstring tendons. And you can see the medial meniscus is so still intact, like and it hasn't moved. Where we did the injection posteriorly appears to have healed. And this is a knee that's just had a significant trauma. So what do you consider that? Is it a win or a loss? So what about bone marrow concentrate augmentation for a meniscal repair where there's no ACL injury? So this is an isolated meniscal repair. There is evidence in the literature that this is a good thing to do. Here's one example. This is a paper that was published in June 2023 in the Green Arthroscopy Journal. Relatively small sample size of 17. Average age is 23. They did have 3-year follow-up, which is nice. And what they documented was that using bone marrow concentrate to augment a meniscal repair led to these 17 athletes getting back to the same level by 1 year and 100% improved above the minimally clinically important difference. So strongly believing that data, this is something I've incorporated into my practice for many years now. This is an example of somebody with an isolated bucket handle medial meniscus tear. So as we all have to do, we reduce the meniscus and then we assess the repairability of it. And so here you can see this bucket handle meniscus tear. Now, are we going to trim this out in this patient? Absolutely not. We're going to repair this at all costs. And wouldn't it be great if we could do something to augment? And well, we are. We're going to use this bone marrow concentrate. So here's the repair. And then we use bone marrow concentrate to inject once again at the meniscocapsular junction. We're trying to stimulate the vascularity to grow into that meniscus and increase the success rate of this repair. But now we're going to switch gears and talk about high-dose PRP for medial meniscus tears. So here's an example. This person just came in the office. You see the date there, November 17th, and look at their MRI scan. Now, this is hypothetically a college junior scholarship athlete. This is an MRI documented posterior horn medial meniscus tear with no other significant ligamentous or chondral injury. What are the options that we're going to discuss with this patient as orthopedic surgeons? Surgical resection, everyone's moving away from that, right? We're trying to save the meniscus. Surgical repair, yeah, we can consider that, but recovery is going to be 3 to 6 months, and and it introduces some surgical risks that we'd rather not have if we could avoid it. If we do that, and this is an athlete that's going into their senior year, maybe they have to take a redshirt year now. So this is becoming a much more important consideration, especially with some of the finances involved now with college athletes. Or we can consider a high-dose PRP injection done in the office using ultrasound, where we can put a 25 gauge needle directly into that tear and also along the meniscocapsular junction to try and stimulate a healing response. And so that's what this patient opted to do. And so on the video here, on the right, you can see we're using ethyl chloride, and we've got the knee position so we can get to the posterior medial aspect of it. We're just making sure that we can see the meniscal tear. And when we look here on the ultrasound, which I apologize, it never shows quite as well as on the actual ultrasound monitor, but you can see right here, this is the joint line, this is the meniscus. It'll start to show, and so this is the meniscal tear right in here. And as we inject, you can see we're injecting at the meniscocapsular junction, we're injecting deep MCL, and then we can even leave the tip of the needle into the meniscus. It won't hold a large volume, but we can put some of that PRP intrameniscular as well. In addition to intrameniscus, we also put the rest of it into the joint. So from a 120 cc blood draw, we make 6 cc's of PRP. We use 1 to 2 cc's in this region, and the rest of it goes intra-articular. Let's talk about PRP for the ulnar collateral ligament. Fortunately, there's a robust literature now supporting using high-dose PRP for ulnar collateral ligament tears, documenting not only the success of the procedure, documenting not only the healing of the ligament, but also documenting return to sport at the same level in a certain percentage of athletes. In this paper that was published in 2024 on the left, these authors document that the return to sport and return to the same level of play can range from 46 to 100%. And so if we look on the right here, this is an ultrasound in the office where that white circle is. This is where the damage is to this person's ulnar collateral ligament, and even to a certain extent to their flexor tendon origin. And so we'll see a hypoechoic defect here. The UCL usually runs right along here. This is the joint line right here. And you can see a lot of hypoechoic destruction off of the epicondylar side of this ulnar collateral ligament. And so that is our target for PRP. Here's another paper. This one was published years back in 2017. Lead author is a well-known elbow surgeon and orthopedic surgeon and sports medicine expert, Buddy Savoy, of course. In this paper, they looked at 23 patients with ulnar collateral ligament tears. 96% were able to return to play and demonstrated reconstitution of the ulnar collateral ligament by MRI follow-up. And so this is, tremendous data to support using PRP first before we ever consider taking someone to surgery. And I know there's a talk probably right after mine on ulnar collateral ligament injuries. And so not to steal any thunder there, but in my opinion, we can't take someone to surgery unless it's a grade 3 tear without trying PRP first. It also seems to be that 2 injections is better than 1 injection, and there may be some marginal improvement for even a protocol with 3 injections, but currently I'm just doing 2 injections, 1 injection a week, separated by 1 week. So here's the example of the needle coming in. You can see the hyperechoic needle. We're targeting that defect in the UCL, and again, even some of the flexor origin. And the key here for me is concentrating this so that we get a high platelet dose. Here's the example of the current protocol. I'm drawing 120 cc's of blood. I'm using a 2-spin system where the first spin is 2.5 minutes. The second spin is 7.5 minutes. We create about 2 to 3 cc's of PRP. So starting from 120 cc's of blood, this is going to be relatively concentrated. And then we give 2 injections 1 week apart. Remember that dose is volume times concentration. And in this example, this exact example, the dose was 3 cc's. The platelet count off of our Hariba hematology analyzer was 1715. When you multiply those two together, that gives you a platelet dose of 5.1 billion platelets per injection. And if we can duplicate that in the second injection, that'll give us a second dose of 5 billion. So over the course of 2 weeks, we're going to put 10 billion platelets at this site to try and stimulate a healing response. So I want to thank all of you for your attention. I think you can see my philosophy here is if we have something that's safe, that has some efficacy, that's based in human biology, why wouldn't we try it, especially for these adolescents and especially for these young adults, these collegiate age athletes?